Welcome back to Critical Connections live from Congress in Honolulu, Hawaii. We will now be going to the live session to see what's new in the latest Surviving Sepsis Guidelines. Following the session, we will be joined by Dr. Richard Savelle and Dr. Chris Carroll, Dr. Lauren Epstein, and Dr. Philip Dellinger as they discuss the CDC's efforts to increase education about sepsis. Thank you for staying with us, and be sure to follow the discussion at #SCCM Live.
Good morning, everybody. I am Todd Dorman, the past president of the Society of Critical Care Medicine, and I want to welcome you to our session today that is the joint session between the FCCM and the European Society of Intensive Care Medicine on the new international guidelines for the management of sepsis and septic shock. Welcome to the ballroom. This is a live webcast event, and we encourage you to use the hashtag that you, I believe, have seen already, but it is hashtag SCCM Live. This session's been assigned that particular hashtag to encourage conversations around today's topic. So I hope that you and anybody who's following this live or on Twitter, as people all over the world can connect through Critical Connections Live, and they can merely tweet to that hashtag and also use the hashtag CCC46 for this Critical Care Congress. Massimo?
Good morning, ladies and gentlemen. My name is Massimo Antonelli. I'm the actual president of the European Society of Intensive Care Medicine. I sit here because the Surviving Sepsis Campaign is the product of the activities conducted jointly between the two societies with a tremendous effort. And as you know, this campaign and the guidelines have been published just 2 days ago. It is a great privilege having the leaders of the Surviving Sepsis Campaign, and one by one is going to present the methodology and the major issues concerning the guidelines. So I invite at the podium as a first member of the leadership, Laura Evans, and he has the task to illustrate the methodology that is behind the Surviving Sepsis Campaign guideline.
And all three will present, and then the Q&A will be at the end after all three have presented, okay?
Great. Thank you so much, Todd and Massimo. It's a real pleasure to be here, and I think I speak for myself, Andy, and Mitchell when we all say that we're really excited to present this fourth publication of the Surviving Sepsis Campaign Guidelines to you today. I'll start by I have no conflicts of interest to disclose. And the first thing I wanted to make was just to draw your attention to what a huge team effort this whole guidelines process is. While we're the ones up here on the podium today presenting some of the results to you, this is a reflection of months and months of work of an enormous number of people, from the guidelines panelists to the group heads to our methodology team, to both the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, to all of the participating societies who sent representatives to the guidelines process, our reviewers who made this a better document for their review, and last but not least, Ms. Deb McBride here for her amazing editorial support throughout the entire process. And I also do want to also acknowledge Dr. Phil Dellinger for his leadership and guidance throughout this process. So I will start with a brief overview of the methods of the guidelines, and then I'm going to pass it off to Andy and Mitchell to get into the sort of the meat of some of the recommendations, which I think is probably what drew most of you to the room today. To go back, you'll remember the first edition of the Surviving Sepsis Campaign Guidelines was published in 2004 and then was revised in 2008 and 2012. We started this revision way back in 2014, and as Massimo and Todd already spoke to, this was jointly sponsored by ESICM and SCCM. The structure of the guidelines is we have a guidelines committee oversight group, which is led by the co-chairs, Andy and myself, and Mitchell. We then broke the guidelines into 5 working groups and designated group heads. So Massimo was the head of the hemodynamics group, Ricard Ferrer was the head of the adjunctive therapies group, Anand Kumar, infection, John Savransky, ventilation, and Charlie Sprung for the metabolic group. We had 3 terrific methodologists led by Walid Al-Hazani and supported by Mark Nunnally and Bram Walkberg, and each group was supported by a methodologist assigned to that group as well, and Gordon Rubenfeld served as our conflict of interest chair. I know this slide doesn't project, but I wanted to bring your attention to all 55 members of the guidelines panel who contributed so much of their time and effort to this process. Many of these represented participating societies, and some were at-large members. None of our guidelines panelists received honoraria for their participation in the guidelines, and the guidelines had no industry input throughout the entire process. We managed conflict of interest by asking each panelist to disclose conflict of interest at the beginning of the panel itself and then annually thereafter. All conflict of interest was self-disclosed and then reviewed by the Conflict of Interest Committee led by Gordon Rubenfeld. Potential conflicts of interest were managed by either limiting voting on topics that were pertinent to the potential conflict of interest, or in cases where a potential conflict was potentially more extensive, a panelist could potentially be reassigned to another group. One of the big challenges that faced this group is in the beginning of 2016, the Sepsis 3 definitions were again co-published by ESICM and FCCM. And just to refresh your memory about that redefined sepsis as a life-threatening organ dysfunction caused by dysregulated host response to infection, and septic shock as a subset of sepsis with circulatory and cellular and metabolic dysfunction associated with a higher risk of mortality. So our panel was faced mid-guidelines process with how do we incorporate these new definitions into this process. And what we ended up doing was, so clearly the new definition of sepsis is very similar to the old definition of severe sepsis, so organ dysfunction associated with infection. So we replaced severe sepsis in these guidelines with the new Sepsis 3 definition and terminology of sepsis. However, the Sepsis 3 guidelines also went through proposed clinical criteria to use to identify patients with severe sepsis. For example, the QSOFA criteria. QSOFA was not used in any of the studies that informed our guidelines recommendation, and thus we could not comment on the use of the Sepsis 3 clinical criteria for the recommendations in this guideline. This is just a brief overview of the schematic of what process we went through with this, and I'll go into more detail about some of these as we go through. So we start by determining the scope of the guidelines, and this was done with the co-chairs of the guidelines and input from previous guideline panelists as well. Panel members were selected. We then went through as a group with the panelists, the group heads, and the guidelines leadership to identify topics and clinical questions that were of priority, followed by the formulation of PICO questions and outcome prioritization. When necessary, we conducted additional systematic reviews, went through and graded systematically the certainty of evidence, formulated recommendations, and then voted on those recommendations. And again, I'll break down some of those in a little bit more detail. Starting with how we selected studies, if we had a new PICO question, we did a search strategy of at least 2 databases with no date limitations on it. If we found a high-quality systematic review, that was included. If we had an outdated but high-quality systematic review, the review was updated and then included. And then we went through and found individual randomized trials and observational studies, and were included in our meta-analyses and systematic reviews. If we had an older PICO question, we updated the search based on the date parameters from the last search, and then went through the same process of a high-quality systematic review and so forth. We use minimum searches of at least 2 major databases with assistance from professional librarians. Then discrete evidence profiles were generated for each PICO question. Grading of the recommendations was done using grade methodology, which we'll talk a little bit more about, which was similar to previous iterations of the guideline. And we did vote on each recommendation. We required 75% of panel members to vote and 80% approval for a recommendation to move forward. If a recommendation did not pass on the initial round of voting, we would look at the comments associated with that, reformulate the recommendation as needed, and revote, and up to 3 times if necessary. Many of you will recognize this from other guidelines processes. We too, and the previous iterations of the Surviving Sepsis Campaign Guidelines, use grade to assess the quality of evidence. There are 5 main factors that go into a grade assessment of quality. They're risk of bias, inconsistency, indirectness, and imprecision, and publication bias, and then some other criteria as well. It starts by looking at the underlying methodology. A high-quality randomized controlled trial starts as a high quality of evidence. Randomized trials can be downgraded, or observational studies can be upgraded to then move to moderate quality of evidence. Well-designed observational studies start at low quality of evidence. And then downgraded controlled studies or expert opinion or other evidence start at very low quality of evidence. Certain elements can decrease the strength of a recommendation. So if a study has characteristics that suggest that there's a high likelihood of bias, if results are inconsistent, including problems with subgroups, if the evidence is indirect, so actually sort of studies a different population. One example of this for the sepsis guidelines would be around if we had a study that addressed a whole critical care population rather than specifically a sepsis population. Imprecise results and a high likelihood of reporting biases were also potential reasons to downgrade a quality of evidence. Other factors could increase the strength of the quality of evidence, and those were if a large magnitude of effect was observed. So if, for example, a relative risk was greater than 2 without not to have confounders, or there was a very large magnitude of effect and limited threats to validity, or if there's a nice dose response grade observed through multiple studies, that could increase the strength of evidence on a recommendation. After the quality of evidence was assessed, recommendations were formulated, and they were formulated as strong versus weak recommendations. And you'll hear this a couple times probably throughout. We used wording of either we recommend or we suggest. So if a recommendation starts with the wording we recommend, that means it's a strong recommendation. If a recommendation starts with the wording we suggest, that means it's a weak recommendation. So when determining whether a recommendation was going to be framed as strong or weak, there are elements that were considered in this process, and they were if the evidence was high or moderate quality, the higher the quality of evidence, the more likely we are to issue a strong recommendation around that subject. If there's more certainty about the balance of benefits versus harms and burdens, again, the more certain we are, the more likely we are to issue a strong recommendation. Again, if there's more certainty or similarity in values and preferences, the more likely a strong recommendation. And resource implications also play into the grading of a recommendation, and so the lower the cost of an intervention compared to the alternatives would be more likely to favor a strong recommendation as opposed to a weak recommendation. One thing that you'll note in this revision of the guidelines, which is new compared to previous iterations of the guidelines, is that we use best practice statements. And as the guidelines methodology community has moved forward, best practice statements have become more prominent. They represent strong but ungraded statements. But it's not sort of just an expert opinion statement that's strong. It has to fit defined criteria, and you'll see the defined criteria listed here. That for a best practice statement to be issued, the statement must be clear and actionable. We must find the message necessary. The net benefit or harm has to be unequivocal. The evidence has to be difficult to collect and summarize with an explicit rationale, and the answer to the last question has to be no, which is that the statement should not be better if formally graded. We also changed the way that descriptions of the evidence were presented in this, and this is just a crosswalk table that we use prose grade descriptions for the purpose of clarity and to keep in line with where the guidelines community is going. So previously you may have seen a recommendation that was framed as a 2B, which is a weak recommendation based on moderate quality of evidence. Now, when you read the recommendations, it will actually say this is a weak recommendation based on moderate quality of evidence. So you don't have to worry about retranslating what is a 2C or a 1A, et cetera. It just tells you that in frank prose. Again, a best practice statement represents an ungraded strong recommendation. The implications of the strength of recommendations matters. So strong recommendations, when you're thinking about what does that imply for a patient? So strong recommendation essentially means that probably most patients would want this recommended course of action, while a smaller proportion would not. Correlate to that is a weak recommendation is probably the majority of individuals would want the suggested course of action, but many would not. As clinicians, the way we can interpret strong versus weak recommendations is, as a clinician, when we're interpreting a strong recommendation, we should interpret that as most individuals should receive the recommended course of action. And then for a weak recommendation, we'll say different choices are probably going to be appropriate for different patients, and that you should really tailor therapy to the individual patient's circumstance. Of course, as with all guideline recommendations, there's always reasons why you might vary from them, and we should never supplant our clinical judgment. So just to finish up before I pass this off to Andy and Mitchell to go into the meat of some of the recommendations, our panel ended up issuing 93 recommendations total. 32 of them were strong recommendations, again, so we recommend language. And 39 were weak recommendations, so we suggest language. 18 were best practice statements, and we had 4 PICO questions on which there was sort of we could not issue a recommendation due to the evidence didn't point us in one direction or another. So with that, I will pass this on to Dr. Rhodes to go into the meat of some of our guideline panel recommendations.
Thank you very much, Laura. Andy Rhodes will be the next speaker, and will illustrate us more in detail some of the principal recommendations. Andy?
Massimo, Todd, thank you very much, ladies and gentlemen. Good morning. My name's Andrew Rhodes. I'm a consultant in intensive care medicine from London. I'm one of the past presidents of the European Society of Intensive Care Medicine and one of the co-chairs of this guidelines panel. It's my pleasure and privilege to start describing some of the results of this process to you. I'm going to be focusing more on the initial resuscitation elements, and then Mitchell will pick up some of the other elements afterwards. For the matter of fact, I've got no financial disclosures to make, but I would say that one of the most challenging parts that we found in this whole process is to manage some of the academic conflicts of interest and some of the challenges where people seem to think they know what they're doing before we've actually been through the evidence process. And it's been quite an interesting process bringing some of these egos and these challenges together. I'm going to just reiterate for a few seconds exactly what Laura has just said. This is a huge thank you to the 58 panel members, many of you who were in the room this morning. I'd also like to thank the sponsoring organisations, the European Society of Intensive Care Medicine, the Society of Critical Care Medicine, the 26 other international organisations that took part, and the senior leadership from previous iterations of the guidelines who stayed with us and advised us through this tricky process, in particular Mitchell Levy and Phil Dellinger. Focusing on the 2012 recommendations is worth to start with. We're talking about initial resuscitation, and perhaps this is where things have changed the most. So I'm just going to take your mind back 4 years and remind you of what we recommended in 2012 with regards to the initial resuscitation. In 2012, we said, we recommend the protocolized quantitative resuscitation of patients with sepsis-induced tissue hypoperfusion. During the first 6 hours of resuscitation, the goals of initial resuscitation should include all of the following as part of the treatment protocol: central venous pressure, mean arterial pressure, urine output, and central venous oxygen saturation. Now, you'll all be aware where this comes from. This came from this study published by Manny Rivers in the New England Journal in 2001. This is the protocol straight out of that study, and this led directly into the recommendations in the 2004, the 2008, and the 2012 iterations of these guidelines. In particular, this resuscitation for septic shock mandated the early insertion of a central venous oxygen saturation catheter, therapy titrated to endpoints of central venous pressure, mean arterial pressure, and venous oxygen saturation, and that drove the need, or drove the requirement, for red blood cell transfusion and dobutamine. Now, this study was important because at the time it was perhaps the only study that had looked at resuscitation of these patients and shown a significant mortality benefit. And clearly, over the subsequent 12 to 15 years, there's been a whole debate and interest in whether this is valid to this day. In the last 4 years, we've had 3 large randomized controlled studies published in a multicentric fashion: the PROCESS investigators, the ARISE investigators from Australia and New Zealand, and the PROMISE study from the United Kingdom. This is the meta-analysis plot from Intensive Care Medicine in 2015, demonstrating that not one of these studies was able to show the same signal to benefit that the previous River study had shown, and when we analyze it all together, the same signal benefit is not present. But you have to remember that a number of the things that we do in tandem have changed. This is data from the PROCESS study. This is just demonstrating actually that these studies are performed in centres that are able to deliver care and some of the elements, important elements of care, reliably and well. These studies were able to deliver about 3 litres of intravenous fluid in the first few hours of the study, and they were able to deliver antibiotics early and in a consistent and reliable fashion. So we have to bear in mind that actually the treatment signal that we're seeing from the River study may have changed because a lot of the basics of care, perhaps driven by educational performance meetings such as this, have changed practice. So what are the caveats or perhaps the limitations of these 3 large studies? Well, the overall management of sepsis has changed, and I think it's changed for the better. In all 3 studies, patients were given early antibiotics and were given 30 mL per kilogram of intravenous fluid prior to randomization. So we're talking about whether there's a treatment benefit over and on top of very good basic care. So we need to be very careful about over-interpreting these results in areas where some of these basic care elements are not delivered. You have to remember that these guidelines are being delivered for practitioners all around the world in the rich resource element areas as well as the less rich. You also should remember that none of the trials showed harm. Not one of these studies demonstrated that the protocol they were using was associated with an adverse outcome. So I would put it to you that if you've got your centre and your hospital set up to deliver care in that fashion, you do not have to rush to change, because it is still valid today. The challenge we have is to understand actually how we can do better. So was the River's work useful? Yes, I believe it was. It provided me a construct on how to understand resuscitation. It told me the elements of what we were doing, and it probably fulfilled all our preconceived biases. What do I take from it today? That we should start early and give antibiotics. We should correct hypovolemia. We should restore perfusion pressure. And in some cases, we may need to do a little bit more. I put it to you that these concepts are as important today as they ever were. And this is what's going to be coming through when we're looking at some of the recommendations. We no longer felt able to just recommend the same Rivers protocol that was there in 2012. So we've had to deconstruct that. We've had to work out what elements of that protocol were important and what it is that we should be suggesting to practitioners, because it is only help in a guidelines process if we're suggesting or recommending you to do things. So a best practice statement we came up with, and I think this is very important. Sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation begin immediately. Medical emergencies. Sometimes we allow our cardiologists and our neurosurgeons and our traumatologists to come up with golden hours and approaches to deliver complex interventions, whereas we've struggled to deliver reliably early antibiotics. We've got to start rethinking about septic shock and understanding that it is imperative and important to get on and treat quickly. If we're looking at the initial resuscitation, I think there's 3 key components that we've got to think about. Getting control of the source of the infection, giving early antibiotics, and getting on with the resuscitation. And in many times, all 3 elements will have to happen in parallel and in tandem. So source control, we recommend that a specific anatomic diagnosis of infection requiring emergent source control be identified or excluded as rapidly as possible in patients with sepsis or septic shock, and that any required source control intervention be implemented as soon as medically and logistically practical after the diagnosis is made. The suggestion from this is that if we have a patient with a perforated abdominal viscus, fecal peritonitis and septic shock, we don't leave them overnight, we get on and treat the patients early. So we're looking for source control, we're looking to deliver early antibiotics reliably and consistently. We're recommending that the administration of intravenous antimicrobials be initiated as soon as possible after recognition and within 1 hour for both sepsis and septic shock. And that's a strong recommendation for both sepsis and septic shock with a moderate quality of evidence. In addition, we're recommending that empiric broad-spectrum therapy with 1 or more antimicrobials to cover all likely pathogens is delivered. And again, this is a strong recommendation, although a moderate quality of evidence. There was a lot of debate and discussion as to how we started the resuscitation and how we actually framed what to do prior to we having complex or more detailed information about the patient. We came up with this recommendation for the delivery of intravenous fluids. This is a recommendation that was debated and was discussed quite strongly in the panel, but actually we believe enable practitioners to get on and start the resuscitation while getting more information from the patient. We recommend that in the resuscitation from sepsis-induced hyperperfusion, at least 30 mils per kilogram of intravenous crystalloid fluid be given within the first 3 hours. I want you to think through what that actually means in practice. In my world, the average weight for a person may be 70 kilograms. 70 kilograms, 30 mils per kilogram is about 2 litres of fluid. So we're suggesting in the first 3 hours of resuscitation, the patient should be given at least 2 litres of fluid. Some patients it may be very quick, some patients you may want to take a little bit longer. But as a basis, that forms the base of your resuscitation. That's a strong recommendation, although the quality of evidence for that 30 mils per kilogram as opposed to 20 mils per kilogram is relatively low. Important, though, is that some patients will need a lot more and some patients won't. So we need to actually understand which of those patients are going to need more fluid, and that means that we need to be there at the bedside. We need to assess the patient clinically, get an understanding of what type of shock the patient's in. That may mean technology such as echocardiography and hemodynamic monitoring. But actually, more importantly, is that we don't just leave the patient once we've prescribed the fluid. We frequently reassess at the bedside to gauge the improvements or not that patient's making. So we recommend that following initial fluid resuscitation, additional fluids be guided by frequent reassessment of the hemodynamic status. What kind of fluids are we suggesting? Effectively, what we're saying is that crystalloids should be used. We recommend crystalloids as the fluid of choice for the initial resuscitation and subsequent intravascular following placement in patients with sepsis and septic shock. And again, that's a strong recommendation with a moderate quality of evidence. In addition, for some patients, they may need something in addition over and on top of the crystalloid. We looked at a lot of the colloids. I'm only going to provide one recommendation here, but it's clear over the last 4 years that actually the evidence base is against using some of the more man-made compounds such as the starches and is more in favour of using albumin-type compounds. So we suggest using albumin in addition to the crystalloids when the patients require substantial amounts of crystalloids if you feel a colloid type agent is going to benefit your patients. Now that is a relatively controversial kind of statement, that recommendation, and you'll note it is a weak recommendation with a low quality of evidence. So we're giving the patients antibiotics, we're gaining source control, we're starting some intravenous fluid. The next important step, or perhaps in parallel to that, is to restore an arterial perfusion pressure. You can see on the slide, this is data from the ASPHAR study looking where they randomized patients to effectively a high or a low target group, demonstrating that actually an initial target of 65 millimeters of mercury for mean arterial pressure seems to be a reasonable starting point. And we use this basis effectively for the recommendation where we say we recommend an initial target mean arterial pressure of 65 millimeters of mercury in patients with septic shock requiring vasopressors. It may be that some patients need a higher mean arterial pressure, and some patients may have an acceptable lower mean arterial pressure. But when you know nothing about the patient, shoot for 65, get more information, and if the patient's got chronic renal dysfunction, it's got chronic hypertension, you may decide to change your targets. So start by aiming for 65 millimeters of mercury, and then titrate when you know a little bit more. How are we going to do it? What vasopressors are we going to use? Well, the first-line vasopressor we found was norepinephrine. We recommend norepinephrine to be used as the first choice vasopressor, and that's a reasonably strong recommendation with a moderate quality of evidence. The challenge or the question we're then faced with is what do we do if the patient's not responding to the norepinephrine, if we feel there's a need for a second-line agent? And effectively, there's two agents that have been studied in reasonable detail, and that's vasopressin or epinephrine in this circumstance. So the conclusion we came up with, and this is a suggestion rather than recommendation, that if you need a second-line agent, we suggest adding either vasopressin up to 0.03 units per minute or epinephrine to norepinephrine with the intent of raising mean arterial pressure to target, or adding vasopressin to decrease norepinephrine dosage. Now this is a little bit of a complex kind of recommendation, partly because the data is kind of complex in itself. Vasopressin has been studied as an adjunct over and on top of norepinephrine, but also as an alternative agent, whereas epinephrine has only been studied in replacement of norepinephrine. The evidence is slightly stronger for vasopressin than it is epinephrine. So the feeling is the second-line agent would be epinephrine, and you'd use, the second-line agent would be vasopressin, and you'd use epinephrine if you felt there was a strong need to add in an inotropic agent over and on top. So what do we do if the patient's not responding in an adequate fashion to this basis? What do we do if the shock's not resolving? Well, the first thing is we need more information. And there's a lot of technology that's out there, and there's a lot of technology that's pushed into the marketplace for us to use. I think what's become clear over the last 4 to 8 years is that actually some of the static parameters as guides to fluid replacement and volume status are very limited in their applicability and their usability in the intensive care setting. And we suggest that dynamic variables over the static variables should be used to predict fluid responsiveness where available and also where applicable. And that's a relatively weak recommendation, but we feel it is important that when we've got the patient on the intensive care unit, the shock's stabilizing but isn't resolved, the patient's on vasopressors and perhaps on a ventilator, we may need more information at that stage in order to direct therapy completely. In addition, for some patients, there has been and there is still a need for the use of a positive inotropic agent. We suggest using dobutamine in patients who show evidence of persistent hypoperfusion despite adequate fluid loading and the use of vasopressor agents. So this may be the patient who's not responding. We've got an echocardiogram. We can see some ventricular dysfunction. The ventricle's not contracting as well as it should be. And in those patients, we're suggesting that actually dobutamine can be cautiously introduced. Now, the previous iteration of the guidelines, as we said at the beginning, were very much based and revolved around the use of central venous oxygen saturation. This was driven effectively from the Manny-Rivers protocol, but a number of studies have now looked at actually whether there's other kind of markers or variables that can be used to guide resuscitation. So this is one of the meta-analytical plots that's straight from the paper, at least the appendix of the paper, where we pulled together the protocols that have used lactate-guided resuscitation, or what may be described as lactate normalization or lactate clearance in order to guide the resuscitation for these patients. So this is why it's important early on to measure arterial lactate, get a measurement, then repeat it if the patient's not responding over the next few hours, so that you can guide your therapy to see if it moves into the desired range. We suggest guiding resuscitation to normalize lactate in patients with elevated lactate levels as a marker of tissue hyperperfusion. In many people's practice around the world, this is probably easier than targeting a venous oxygen saturation, and it's definitely easier than inserting a complex, sophisticated venous arterial saturation catheter. So we're beginning to bring up a picture where we're starting intravenous fluids early, we're giving early antibiotics, we're gaining source control. We're suggesting that actually we restore arterial perfusion pressure very early with vasopressors, and if we're going to use a vasopressor, norepinephrine is our first-line agent. And then we're titrating the few patients who aren't responding to this by having a complex understanding of what's going on with that patient and then targeting therapy appropriately. So to summarize this part, I think it's important to recommend that sepsis and septic shock are medical emergencies. We should start resuscitation early, achieve source control as quickly as practically possible, give intravenous fluids and early antibiotics. It's important actually that we don't remember that this can be done from a distance, that we have a doctor or a nurse that's got the right level of competencies and skills and training at the bedside, because actually it's not just the initial assessment, but it's the frequent reassessments of that patient that's probably going to make the difference. And it's the frequent assessment of the patient's volume status that's critical in this resuscitation period. And we're now changing the paradigm a little bit rather than being purely on venous oxygen saturations to suggest that actually in many patients a measurement of lactate and targeting a lactate clearance so that we're seeing a 10% reduction in lactate in interim measurements is a useful guide to improving the resuscitation of these patients. Thank you very much.
Thank you very much, Andy. Maybe it's worth to remind that you may find all the evidence tables at the end of the document into the appendix. After a past president of the European Society of Intensive Care Medicine, we'll have a past president, a former president of the FCCM. And Mitch Levy, who is going to be the next speaker, is also one of the founders of the campaign since its launch at the beginning of the year 2000. Mitch.
Thanks, Massimo. I'm going to pick up where Andy left off, except for the accent. So I'm going to show you some of the rest of the guidelines. In particular, I'm just going to show you the ones that are different from 2012. I'm starting with the screening for sepsis and performance improvement. Since 2012, as many of you know, we published the results of the 30,000 patient database from the Surviving Sepsis Campaign that showed a significant association between improved compliance and reduced mortality. In addition, there are several meta-analyses now that show association between decreased mortality and increased compliance with the use of sepsis bundles. And that just demonstrates what I just said. There are data about to come from the New York State initiative that mirror what we've published already, that shows, again, improved compliance associated with decreased risk-adjusted mortality. Under diagnosis, we recommend that routine microbiological cultures, including blood, be obtained before starting antimicrobial therapy. And again, the difference here is last time in the campaign guidelines, we recommended an associated 45-minute delay. It was felt that that was so arbitrary that it was dropped from this year's set of guidelines. This is an important slide because the need for antibiotic stewardship has been highlighted more and more. We have a session tomorrow, a joint session with CDC, in which we'll talk extensively about antibiotic stewardship. And I think it's important because the campaign in many ways has been responsible for strongly advocating appropriate antibiotic initiation quickly within 1 hour of identifying patients with sepsis. And part of the reason that we feel appropriate and good about making that strong recommendation is by marrying it to antibiotic stewardship, so that as soon as you give the antibiotics very rapidly, we begin to reassess the patient to ensure, in fact, that the patient does have the suspected sepsis. So this is the first recommendation, that an empiric antimicrobial therapy be narrowed once pathogen identification and sensitivities are established or clinical improvement is noted. In addition, we recommended the duration, and as we all know, it's not uncommon in our hospitals to have people on antibiotics much longer than necessary because the order to stop antibiotics simply goes undone. And so we recommended that an antimicrobial treatment duration of 7 to 10 days is adequate for the large majority of serious infections associated with sepsis and septic shock. And in addition, as I mentioned already, we recommended, and this is a best practice statement, a daily assessment for de-escalation of antimicrobial therapy in patients with sepsis and septic shock. And finally, we maintained the week recommendation that we had in 2012 as part of this overall approach to antibiotic stewardship to potentially use procalcitonin levels to shorten the duration of antimicrobial therapy in patients with sepsis and septic shock who have a clinically compatible picture at 3 and 5 days. Corticosteroids, the story that will never die. I show it to you. This hasn't changed. I think the wording has changed a little bit. We always have debates amongst the panel of how strongly to recommend against corticosteroid use, and yet essentially this really hasn't changed. We recommend against using it unless we are unable to restore hemodynamic stability, whatever that means. And so it again leaves to all the clinicians and all of us out there in our practice to decide whether or not we want to use use corticosteroids when we are not able to achieve hemodynamic stability, whether that's at the end of one vasopressor agent or when you begin to add another. I will leave that unsaid for all of you. Mechanical ventilation. This statement about using higher PEEP is stronger than in 2012 based on some of the analyses meta-analyses that have been published. It's still a weak recommendation, but with a moderate quality of evidence to use a high PEEP over a low PEEP strategy. Obviously, there have been a number of studies published on proning in ARDS, sepsis-related ARDS, since 2012, and so the recommendation to use proning over supine position is now a strong recommendation based on moderate quality of evidence. continuing in mechanical ventilation based on a number of the trials that appeared in the New England Journal since 2012 that suggested harm associated with high-frequency oscillation. We have a strong recommendation against the use of HFOB in adult patients with ARDS, sepsis-induced ARDS. And because of the Balti trial that some of you may have heard Gordon Bernard talk about from the ARDSNet in the U.S., a strong recommendation against the use of beta-2 agonists for the treatment of sepsis-induced ARDS in adult patients. And finally, this is a new recommendation. This is suggesting the use of low tidal volume strategy for patients with sepsis-induced respiratory failure, but without meeting the criteria for ARDS. And that's a weak recommendation with a low quality of evidence. Glucose control. So, as you know, a lot has been published in 2012. This is a recommendation to use a protocolized approach for the control of blood glucose, but not to start it until 2 consecutive blood glucose levels are over 180 milligrams per deciliter. And the target for this protocolized approach should be less than 180 rather than the low glucose, the tight glucose control that we saw used in earlier iterations of the guidelines. And finally, that blood glucose values be monitored every 1 to 2 hours until the protocol and glucose levels are stabilized. These are new recommendations based on the controversy and concerns about the point-of-care testing and using capillary blood at the bedside in critically ill patients. So we recommend that glucose levels obtained with point-of-care testing of capillary blood be interpreted with caution, as such measurements may not accurately estimate the true glucose levels in arterial blood or plasma glucose levels. And again, if you have the availability of an arterial catheter, use the arterial blood from the arterial catheter to monitor glucose levels. Renal replacement therapy, this is also a new recommendation this year, suggesting against, it's a weak recommendation, suggesting against the use of continuous renal replacement therapy in patients with sepsis and acute kidney injury for creatinine levels alone without any other definite indications for dialysis. So there are several new nutrition recommendations in the guidelines based on the data that have been published in the New England Journal and other journals. This is a recommendation against the administration of early parenteral nutrition alone or parenteral nutrition in combination with some enteral feedings in critically ill patients who can be fed enterally. So essentially, this is a strong recommendation that if you can use the gut, you should use the gut rather than early parenteral nutrition. The second recommendation is for patients who cannot be accessed, in whom early enteral feedings is not full enteral feedings is not possible. We still recommend it against the administration of parenteral nutrition because of the higher risk of infections and other complications, but rather to either initiate IV glucose alone or early trophic enteral feedings. So 2 recommendations, both against the use of parenteral nutrition early, one in patients who can be fed enterally and the other in patients who cannot be fed enterally. This is suggesting the early initiation of enteral feeding rather than a complete fast or only IV glucose in critically ill patients with sepsis who can be fed enterally. And then suggesting early trophic or hypocaloric or early full enteral feedings in critically ill patients with sepsis or septic shock. And if trophic or hypocaloric feeding is the strategy, then the feeding should be increased as quickly as possible according to patient tolerance. This is addressing the PICO question about whether early hypocaloric feeding is adequate or reduces mortality, especially in surgical patients. And in fact, the meta-analysis and the data table suggested that that's not the case, so we recommended to advance feeding as quickly as possible. Another important new recommendation in terms of nutrition, and that is recommending against the use, it's a weak recommendation, against the use of routinely monitoring gastric residual volumes at all in patients with critically ill patients with sepsis or septic shock. However, it was suggesting that the measurement of gastric residuals in patients with feeding intolerance or who are considered to be a high risk for aspiration, again, a weak recommendation. And finally, also in nutrition, a new recommendation suggesting the use, although a weak recommendation, to use prokinetic agents in critically ill patients with sepsis and septic shock. And finally, these aren't new, but I felt I had to include them anyway, reminding us about setting the goals of care, recommending that goals of care and prognosis be discussed with patients and families. This is a best practice statement. Recommending that goals of care be incorporated into treatment and end-of-life care planning, utilizing palliative care principles where appropriate, a strong recommendation, moderate quality evidence, and finally, suggesting that the goals of care be addressed as early as possible in family meetings, but no later than within 72 hours of ICU admission. And that's a weak recommendation, low quality of evidence. I'll say thank you, and I was going to show you the slide on the panel, but thank you very much.
So we have a few minutes left. There is another session in this room immediately there after ours, so we are going to have to move along, but there is some time for some questions. There may be some questions that come from the Twitter feed, but there are some mics set up near the front. So please try to keep your question as streamlined as possible.
Awesome, Abdul, thank you for a great presentation. My question is, if you don't have access to cardiac output evaluation, which one to choose if the patient is refractory to norepinephrine, vasopressin or dobutamine?
So we were very clear that we did not recommend cardiac output measurements for these patients. What we suggested was that actually frequent reassessment, and that can be clinically delivered and clinically done, is important. There is an increasing use of echocardiography in these patients, and where available, some of the hemodynamic monitoring technologies can help. I think it's clear that these patients will be on norepinephrine if the patient's cool and shut down. The next line that we would suggest is to add in vasopressin if there's a requirement to increase the pressure. And if you need to increase the perfusion, there's a feeling that we need to increase the perfusion because there's documented ventricular dysfunction, we would suggest adding in dobutamine.
Please.
Yeah, I see that you left out recommendation for CVP monitoring. In order to infuse the vasopressors, we are going to need a central line. Why don't we measure the CVP? You make rounds now, and it's a flip of the coin to know what the volume status of the patient is.
That's not quite accurate. We did not suggest that you did not use or measure central venous pressure. Clearly, these patients will require, or many of them will require, the use of a central venous pressure line in order to deliver the therapies. In those patients, especially in the emergency department setting, we would suggest that you do measure central venous pressure. There has to be a recognition that the applicability and the usability and the reliability of the data that comes from that are limited, and there are better measures available to predict volume responsiveness and volemic status. But actually, in some patients, it may be the only central measure you've got, and at least if it's in extreme values, can provide some insights and guidance for therapy.
Thank you. We use the stethoscope, and there is no any study that shows that it makes any difference.
Over here, please.
Hi, thanks. Mitch, Bill Pruzzi, Henry Ford these days. Your point about gastric residual testing is interesting. Did you guys consider the literature on post-pyloric feeding versus pre-pyloric feeding and the meta-analyses that have been done in that circumstance? And do you have any thoughts about that?
I think the feeling was that since 2012, no literature came out that would support post-pyloric feeding over gastric feeding, and so I don't think we had a recommendation change this iteration.
Okay, I'll send you an email.
Please, here.
Katrina Jene from Henry Ford Hospital. Thank you very much for your very hard work on all of this. You point out that early resuscitation is very important. In order for us to early resuscitate, we need to identify the patient. Part of the early goal-directed study was early identification using CS criteria and other risk stratification tools such as lactate. in your new publication regarding the sepsis guidelines, you don't have really clear identification tools given to the clinicians at the bedside. And I was wondering what your take is. How do you identify these patients early? And again, this was also part of the early goal-directed study, which had not been done before this had been implemented. Thank you.
I'm not sure we have enough time to answer that question fully, but I will tell you that I would send you back to the Surviving Sepsis Campaign website, where the tool that we've been using for the last more than 10 years is still on that website, because it's still a tool that can be used for identifying sepsis early. The recent publication of the new definitions was in a data set that was already infected. So using SIRS to identify infected patients is still appropriate. And there are a number of editorials, especially one by Jean-Louis Vincent, that came out within the last few months that emphasized that point.
One other question. You, Dr. Rhodes, mentioned that lactate is a measurement of perfusion. I would like to have this kind of this is not a measurement of perfusion. Lactate tells us if there is a metabolic demand for oxygen more than it's kind of met.
The lactate is most certainly not a measurement of perfusion. There are multiple reasons why the lactate may go up. The point we were trying to make was that actually in patients who present with sepsis and septic shock with a high lactate, the lactate coming down is a marker of improvement. It does not mean to say that actually the therapy you're doing is making the lactate come down, but actually it can be used as a guide for resuscitation, because it's quite clear that actually those patients whose lactate does reduce and clear do seem to have a better outcome.
So would you stop fluid resuscitation after the lactate has cleared to, let's say, 1.5? And blood pressure appears to be as kind of 70s.
We get in danger of getting into a little bit too much detail. Our suggestion is that actually that we start intravenous fluids quickly. We restore perfusion as well as we can by restoring volemic status, by restoring perfusion pressure, and if necessary, some inotropes. Once the patient is hemodynamically stable, we have to think very carefully about giving additional volume, because there is a clear signal that actually at that stage, excess fluid is associated with a worse outcome.
So how do you titrate after this? How do you titrate the fluids after this?
So this is where our recommendation that frequent reassessment and the utilization of technology where available can help you in that decision making.
Okay.
We have a Twitter question before we go to the next one at the mic. A person asked you to clarify why steroids remained in the guidelines and why 200 milligrams.
Perhaps I can answer that one. I have a little bit of an academic conflict of interest because I'm on the management committee of the adrenal study, which is a very large randomized controlled study being performed by the ANZIX group in order to answer this question. Because there's little to no data that's become available over and on top of the 2012 guidelines, we didn't change the recommendation from 2012. That is where it was. We are well aware that actually in the next 6 months to a year there's going to be a whole lot of new data that's going to come through, and at that point that recommendation may well have to change depending on what the studies show.
Okay, thank you. Over here, please.
There's a lot of challenge of giving 30 milliliters per kilogram to patients with a history of CHF and or hemodialysis patients. Will you in the future be analyzing these two subgroups and giving better recommendations, please?
So that's a great question, and one for which there's a lot of misunderstanding. There was a recent excellent manuscript by Vinnie Liu in the American Journal of Respiratory and Critical Care Medicine that looked at applying the sepsis bundles for patients with intermediate lactate of 2 to 3, and they found that the associated survival benefit was found in patients with CHF and end-stage renal disease. So the difficulty in administrating fluids in patients with renal disease or CHF is mainly physician-driven, not patient-driven.
Over here.
Hi, very nice summary, Catalina Teba, Cleveland, Ohio. For the patients that are malnourished, do any of the nutritional guidelines change if they present to the ICU malnourished? You still wait 7 days?
So the PICO questions did not specifically address the population that comes in malnourished, but that's so we'd have to go back and look at the original studies that informed the recommendations, and I think many of the original studies that informed those recommendations did not include a pre-malnourished population.
Yeah, a number of the studies have specifically excluded that population.
So I know we're going to get one in. We may get both of these questions in.
I don't know. Mine's kind of long. Hi, everybody. Can you guys please comment about how this is going to affect the CMS regulations regarding compliance? I used to have fantastic compliance until CMS came along.
Well, I think in the next session, Dr. Sean Townsend is going to address this specifically, and Sean really is the expert in how it's going to affect CMS. So I think I won't make a comment on that.
Go ahead, our last question, please.
Really quick on the lactate issue. And some people have suggested that if you have a patient whose lactate is rising, it may even be an adaptive response. And Paul Merrick has written about, not chasing lactate, but the recommendations still say the resuscitation goal should be normalizing. So what do you do with a patient where you're resuscitating and other data you feel is telling you the patient is improving and yet the lactate's rising? Does that alter your resuscitation strategy?
So the data overwhelmingly supports the use of lactate. And I know there are a lot of opinion pieces that would like to argue with what the data say, but there are a number of data, and including the meta-analysis we did for the guidelines, that simply show that lactate can guide therapy, and that hypoperfusion is associated with elevated lactate levels. There's no question that there are other things that elevate lactate. So there can be a physiologic misunderstanding about lactate, but the data suggests strongly that the use of lactate is still appropriate.
And I would add that it is a weak recommendation, so obviously it should be individualized as well.
So we are at the end of our time and the end of the session. Thank you very much for everybody that's in the room, and thank you for those that were on Twitter that were following us.
Thank you.
We're back for the live debrief on the session we just saw. Again, we welcome Dr. Lauren Epstein from the CDC and Dr. Philip Dellinger, a senior author of the 2016 edition being unveiled here today. Alongside them are our two co-hosts, Dr. Richard Savelle and Dr. Chris Carroll. Thank you all so much for being here. Now I will turn things over to the panel, starting with you, Dr. Savelle. Please introduce yourselves and begin the discussion.
Thank you very much, Andrea. Again, my name is Richard Savelle. I'm the Director of Adult Critical Care Services at Maimonides Medical Center in Brooklyn, and I'm a professor of clinical medicine at the Albert Einstein College of Medicine in New York City.
I'm Phil Dellinger. I'm professor of medicine at Cooper Medical School of Rowan University and chief of the Department of Medicine at Cooper University Health.
Hi, I'm Lauren Epstein. I'm an infectious disease physician at CDC, and I work in the Division of Healthcare Quality Promotion at CDC. And the mission of the division is to protect patients by preventing and containing infections. And I work on sepsis initiatives within the division.
And my name is Chris Carroll. I'm a pediatric ICU physician at Connecticut Children's Medical Center and professor of pediatrics at the University of Connecticut. And I'm going to start, but before we start, I know we told our audience to stay quiet, but are you guys all having fun? All right, we can do a little better than that. You guys having fun? All right, that's good. All right, so Dr. Epstein, I'm going to start with you. So CDC has been focusing a lot on sepsis lately. Can you tell us a bit about that initiative?
Yes. So sepsis is an important public health burden, and we know that many patients that have patients with sepsis that develop infections are usually outside of the hospital, and many of these patients recently accessed healthcare services or have underlying medical conditions that require frequent care. So we've launched a national campaign partnering with stakeholders, academic organizations, and other partners focusing on increasing sepsis awareness among healthcare providers and among patients to make sure we empower patients to understand the relationship between infection and sepsis and prevention of infections that lead to sepsis. We're also working on a national assessment to identify clinical characteristics and underlying risk factors among patients with sepsis so we can better target prevention measures. And we piloted this project actually in New York, and we've expanded it to 9 sites throughout the U.S. And we're actually actively doing data collection now, including both adults and pediatrics. And we're also working on better tracking of sepsis. So right now we track sepsis using administrative data or death certificates, which we know can be unreliable over time and is subject to many limitations. So we're working on tracking sepsis using objective clinical measures so we can look at it more stably over time. So we're excited about all these projects, and I'm excited to be here with all of you talking about it.
spend a little time with you, Dr. Dellinger. We know you've been involved with these guidelines since their inception back in 2004, and I guess you asked to make some comments about some of the hemodynamic monitoring and some of the changes and maybe some clarification.
So for those of you that heard the guidelines presentation, realize that we've gone from recommending the Rivers criteria for early resuscitation for hemodynamics to instead having a variety of options that can be used for initial assessment and reassessment. I think a lot of people do not understand, a lot of healthcare providers don't understand when we say it's better to do dynamic than static, the difference between dynamic and static. Static means that you are going to measure one single point and that's it. So you measure a CVP, that's a static variable. You take one blood pressure, that's a static variable. If you have a dynamic variable, it means that over the measurement period, there's an opportunity to see change. Example would be a passive leg raise or a fluid bolus, and you're looking at any change in flow. So they're dynamics. There's the capability for the story to change over the measurement.
So both CVP and blood pressure, though, could be used as dynamic variables if you're assessing response to the fluid you're giving.
Excellent point, Chris. In my opinion, they could. If your CVP went up with a fluid bolus, that does have dynamic characteristics. And if you gave 2 liters of crystalloid to someone whose blood pressure was 70 systolic and it went to 90, that would be a dynamic change. So you're letting the story can change over the measurement period.
Because I could see people saying, oh, we're never going to check CVP again. We don't need to follow that anymore. But that's not really true. It's more about following up on the patient, about reassessing the patient and their condition in response to the therapy that you're giving.
That's correct. And the guidelines are not saying don't measure CVP. CVP remains a viable option to integrate into the total decision-making process. We're just saying that it's not mandatory that you use CVP. It's still one of something that you could use. And the point that was made in the session by one of the questions is, hey, if they're on vasopressors, we already have a central line in place, easy to measure CVP, why don't we measure it?
The other interesting points that either of you should address is some focusing in on some of the important issues relating to antimicrobials. And I guess either of you can take this. We were going to talk about topics such as de-escalation or some of the new words around the different kinds of antibiotics that can be used.
Why don't you do de-escalation, and I'll pick something else to talk about.
Okay, sounds good. So, well, first of all, it's really exciting to hear how much stewardship is a part of the guidelines. And I think that, stewardship is really a patient safety issue and making sure that patients are getting the right antibiotics at the right time for the right dose and the right duration. And it shouldn't be confused with not giving patients antibiotics, but just making sure that we're thinking about those things when administering antibiotics. And as it was mentioned in the guidelines and during the talk, a lot of times with sepsis, we don't know, we may not have an infectious source, or it may be appropriate after a day or two to de-escalate therapy. And I think having stewardship involved and daily reassessing antibiotics is very important. As we're learning more about some of the effects that antibiotics can have on the body, I think it's really important to make sure that we're using it with the information that we have and making decisions about duration.
And if I could jump in, because I remember we were discussing before the age-old complex question of how long, Lord, how long, and this constant tension as a critical care practitioner of long enough, watching the patient hopefully start to get better, giving them prolonged if it isn't an infectious disease process at all, and versus this aggressive de-escalation that to some degree appears to be associated with improved outcomes. Would you like to comment?
Well, I think, a lot of doctors, anyone taking care of a patient, you don't want to stop antibiotics when someone's doing well, and you don't want to stop antibiotics when someone's doing poorly. So everybody runs into that question, and it's hard to know the duration. I think that there's more evidence pointing to the fact that shorter durations, patients do just as well with shorter durations in certain types of infections than long durations. And I think we're learning more about that as we're getting more evidence. It seems like it's going that direction, that we can use shorter durations. Not in every type of infection, but in many infections, we're actually learning and thinking about community-associated pneumonia and abdominal infections, that actually if we have source control, we can reduce the timing of the duration of antibiotics.
Right, I was thinking of, I work in a surgical unit where, exactly as you pointed out, early aggressive source control, but perhaps not as long a duration of antibiotics.
I'll throw a question to Dr. Dellinger. One of the things that's new in this guidelines is the new Table 6, where we talk about combination therapy versus multi-drug therapy versus broad-spectrum therapy versus empiric therapy. I was hoping you could maybe elaborate on some of that, because I think some people have found that a little confusing.
So there are a lot of definitions floating around for antimicrobial therapy, and when you initially encounter a patient with infection-induced organ dysfunction, what we call sepsis in the guidelines, you usually don't know the organism. So your antimicrobial therapy is empiric, and it needs to be broad spectrum, because you don't know the organism, you often don't even know the source, so you cover broad, and it's empiric. Hopefully over time you identify the organism, and now that you know the organism, you may hone it down to one antibiotic, or in some circumstances you say, I'm going to use 2 antibiotics against that bacteria or microbe, and that's combination therapy. And the last word, the term that's floating around, is multi-drug, and that's sort of generic. It could be that I gave 3 drugs as part of my empiric broad spectrum. That's multi-drug. Or I gave 2 drugs to target a known bacteria as combination therapy. That's multi-drug. So multi-drug is probably not a good term to use.
All right, well, thank you. I think that helped a lot.
But just to follow up, though, I think the reason it was put in the guidelines is to continuously have clinicians who are taking care of patients with sepsis, again, do this tension of aggressive, broad-spectrum antibiotics early, but only early. And then you have to be continuously thinking and reassessing and readdressing why are you doing what you're doing. Would you agree with that statement?
I would. And let me add a pet peeve of mine. We don't...
I just said?
No. Oh, no. So you can't be so concerned about antibiotic exposure that you would allow a patient that's hypotensive, for example, and you don't know why. It could be infection, it could be something else. And you don't want to say, I'm going to wait and start antibiotics when I know it's infection. If you don't know why there is acute, serious, potentially life-threatening organ dysfunction, you got to start antibiotics until you know it's non-infectious, and then you could stop it.
Yeah. I think one of my favorite expressions is, we're in an ICU, for goodness sakes. If I can want to watch that patient continuously, I can stand there at the bedside and watch that patient continuously. I think if I had to put a theme together for these guidelines, it's that the importance of frequent reassessment. Nothing replaces an attentive provider at the bedside.
I'm sorry. Go ahead. So,
real quick. So, the CMS in the U.S. now, Center of Medicare and Medicaid Services, has mandatory collection of quality indicators, and one is that the patient is being reassessed after the 30 mLs per kg fluid. And there's been pushback by physicians saying, well, you give us these options for reassessment, but none of them's proven to make a difference in outcome. And what I tell that person is, if you had septic shock and you got 30 mLs per kg of fluid, would you want to be reassessed by a healthcare practitioner afterward? Because that's what the CMS is saying. So, and I haven't gotten a no answer yet. Sorry.
No, fantastic. One of the other things we talked about letting you speak about before is some of your perspective looking back all the way to the 2004 guidelines. And reading them myself, it was kind of exciting to see some degree of stability over time, meaning that we're sort of heading in the right direction. And I'd love to hear your thoughts on that.
When you look at the 2004 guidelines, as they went to 2008, there were some corrections, so some course corrections. And then from 2008 to 2012, there were course corrections. So there are course corrections that occur independent of new literature, new evidence-based medicine. So eventually, you'd like to decrease the magnitude of the course directions so that each time the guidelines are changing almost entirely by changes in evidence-based medicine. So I think the new guidelines are great. I think that Laura Evans and Andy Rhodes and Waleed Al-Hazani have done a great job. I love the changes that they have been responsible for engineering in these guidelines.
I'd like to throw it back to Dr. Epstein. Do you have any final comments on these new guidelines and some of the challenges or controversies?
Well, I think that, like I said, I think it's great that stewardship is involved, and really I think that it's important to understand that stewardship is really a way to provide clinicians with support in choosing antibiotics and figuring out the duration and the dose, and I think that it can be a really important asset for clinicians and healthcare facilities, and it's not one size fits all depending on expertise and what's available. I think that in many ways it aligns with the principles of sepsis treatment, so it's good to see it as part of that, and it's been an important focus of the division that I work in at CDC.
Great. Dellinger, do you have any final comments?
Are you going to let me put my helmet on?
Sure. We've only got
we got 30 seconds. So I was teasing them
I'm a big fan of props.
Yeah, that I should get to pick a winner between the guidelines and the bacteria, and then put the helmet on like Corso does on college football game day. And so I was going to reach behind, and instead of pulling out the bacteria helmet, I was going to pull out the Surviving Sepsis Campaign Guidelines helmet as the winner. My prediction.
All right, well, we're ready to... We can all agree.
Dellinger, I give it a 10, so maybe next year. Thank you so much, Dr. Epstein, Dr. Dellinger. And that is all the time we have for this segment. Late-breaking articles from Congress, including this one on the Surviving Sepsis Guidelines, are available at FCCM.org/literature. Thank you so much to everyone who has joined us throughout this day on our Critical Connections live broadcast. It has been a gorgeous day here in Honolulu. You'll be able to replay the materials from this live broadcast at sccm.org/live. Also, a huge thanks to our wonderful co-hosts, Dr. Richard Savelle and Dr. Chris Carroll. They were amazing today. Your insight was priceless. And for Critical Connections Live, I'm Andrea Fasano. We hope to see you all next year in San Antonio, Texas for the 47th Annual Critical Care Congress. Mahalo.